Case sharing 44 years, premenopausal. 12-1998, incidental finding of right breast lump FNA, plus VAFA malignant cells. 12-1998, right total mastectomy with axillary dissection. Metastasis workup, CXR, CT Abbott and pelvis, bone scan, LFT, RFT, no metastasis. Case sharing 2 pathology. Primary tumor, infiltrative ductal carcinoma. Bloom's and Richardson's grade 3. 3.5 cm largest diameter. Extensive lymphovascular invasion LV. All resection margins clear. Case sharing 2 pathology 2 biological markers lymph nodes. 21-30 lanes. 2 cm largest. Extensive extracapsular extension. Biological markers. ER200, PR200, CERB2+, case presentation adjuvant therapy. Chemotherapy, 199 to 799. Adriamycin 50 mg/m2. Taxol 175 mg/m2. Cyclophosphamide 600 mg/m2. Sequentially at 2 weekly intervals with GCSF support. Radiotherapy. Chest wall and SEF 50 grays and 25 FRS. Hormonal therapy. Tamoxifen 20 mg QD since July 1999. 2. 3. Risk of local regional recurrence. Risk of recurrence after lumpectomy. No RT 26% in 5 years. WBRT, plus boost 7%, tilde 4%. Risk factors. Margins. Age. Lymph node status 0, 1 to 3, greater than 4. Estrogen receptor status plus VA/VA. Tumor nuclear grading I/2/3. CERB2, HER2, status plus/. Tumor size. Risk of distant metastasis. Age. Histology subtype. Tumor grade. Tumor size. Chest wall and skin involvement. Lane status, 0 1 3/4 9/ greater than 10. ER/PR status. Multigene array expression profile. BRCA status. Pathology of breast cancer 1 ductal carcinomas. 3 histopathologic classes. 1. Ductal carcinomas, greater than 90%. 2. Lobular carcinomas, tilde 3%. 3. Special forms of breast cancer, tilde 6%. Ductal carcinomas. Histologic type of breast cancer adenocarcinoma cases, %. Infiltrating ductal 70 to 80. Medullary 5 to 8. Mucinous colloid 2 to 4. Tubular 1 to 2. Papillary 1 to 2. Intraductal 2 to 3. Molecular/intrinsic subtyping. Microarray identified gene expression profiles or gene signatures. Consistent with the heterogeneous collection of biologically distinct diseases. Molecular portrait first pioneered by the Stanford and UNC groups, Sawley and Prabhu. Divides breast cancer into 2 main types, using 5 subtypes, ER positive, ER negative. Luminal A HER2, SERB2, plus. Luminal B basal-like. Normal-like. Breast cancer molecular subtypes, clinical course and treatment. %. Clinical course. Prevailing treatment. HR plus/HER2. Luminal A. 30 to 38. Indolent. Bone, soft tissue. Endocrine agents. HR plus/HER2 plus. Or high Ki67. Luminal B. 15 to 24. Aggressive. Viscera. Anti-HER2 agents. Chemotherapy. HER2 plus/HR. HER2 plus. 8 to 10. Very aggressive. Viscera and SNES. Triple negative. Basal-like. 15 to 25. PARPI promising. BRCA half mutation. less than 5. Moderately aggressive. Chemo, PT salts. Apocrine, adenoid cystic and low-grade metaplastic tumors are also included in the TNBC group. These rare subtypes have a very good prognosis. Normal breast claudin low HER2 enriched luminal B basal like luminal A. 12. Genomic assays for breast cancer prognosis. Oncotype DX. Genomic grade. Momoprint. Buys. JNCI, 2006. Paik, et al. Nejm 2004. Sotaru, JNCI, 2006. X, CA 15.3, Saya, CA 125, ALPAST. 1. Safna T. et al. Jacqueline Oncol 1996, 14, 2738-2746, basal-like breast cancer, frequent and early relapse. High risk of early relapse. Constant risk of relapse. Dent, Clin Canceries 2007. Triple-negative breast cancer, distinct behavior. Risk of relapse. Over time. Relapse pattern. High risk, early timing. Sites of involvement differ from luminal. SNES involved in up to 46%. Sites involved. N. Bone. Soft tissue. Viscera. TNBC. 79. 13%. 74%. ER plus. 123. 39%. 7%. 54%. HER2 plus. 78. 12%. 81%. Dent, Clin Canceries 2007, Leitke, JCO 2008, Lin, Cancer 2008. Case sharing treatment I. X, CT thorax, PET/CT scan, MRI brain. MRI brain, multiple secondaries. Common sites of metastasis. Most common. Bone, (40%). Others. Brain, triple negative, HER2 plus. Leptomeningeal. Lymph nodes, contralateral axilla, SCF, IMC mediastinal etc. Liver. Lung. Soft tissue. Workup for recurrence physical examination. Blood tests, LFT, tumor markers, CA 15.3, Saya, CA 125. Local and contralateral breast, MMG, US breast, MRI breast. Metastatic workup, CXR, US liver and abdomen, CT, PET/CT, whole body MRI, NM/Mr. bone scan. Biopsy of metastasis, histological confirmation/change of biological marker status. Individualized therapy and personalized medicine. Adjusting treatment to the tumor characteristics. Personalized medicine. Adjusting treatment to the patient characteristics. The right treatment. For the right patient. At the right time. 22. ERPR. HER2. Treatment of metastasis. Aim of treatment. Control disease. Prolong life curative intent for a selected group. Relieve symptoms. Maintain quality of life. Question mark? Treatment 2701, whole brain RT stop tamoxifen. 901, Herceptin 2 mg/kg weekly. CA 153, greater than 1444. Vinylbine 20 mg/m2 weekly added. CA 153-50. Cont. Weekly VBL plus Herceptin with GCSF-TIL. 10/2002 MRI brain -1 cm lesion in left cerebellum. Other lesions regressed. Stereotactic radiosurgery to cerebellar lesion, 16 Grays X1. Treatment 3. After 52 courses of VBL plus Herceptin, stopped VBL and continue with Herceptin every 3 weekly and started Femara 2.5 mg QD. 1103 CA 153 243 PET scan/m.r.i. Multiple liver mets, no other systemic disease. Restarted on VBL and Herceptin every 2 weekly. Continue Femara 2.5 mg daily. 1103 to 1204 CA 153 243 50 0704 MRI-PR of liver mets. Treatment for VBL 105 to 9052 2006 CA 153 131 Cont plus Herceptin. 0205 MRI liver ST. 0205 MRI brain. 3 new mets, SRS, 16 to 18 grays. 2006 CA 153 131 5 2006 MBI brain and liver, new lesions. Treatment V. 9 2006, bending lapatinib, Cont VBL plus Herceptin, PT. Reluctant to change chemo in fear of side effects. 6 2007 rapid progression of liver mets, ASD/ALT, greater than 500. 8 2007 switched to Zelida and lapatinib. Treatment for local regional recurrence. Surgery. Mastectomy, operability rate 75 to 100%. 5 years relapse-free survival, 55 to 73%. 10 years survival rate, 60 to 70%. Chest wall recurrence, less than 10%. Important prognostic factors. Disease-free interval less than 2 years versus greater than 2 years. Skin involvement. Lymph node status. ER/PR status. SERB2 status. BRCA1/BRCA2 mutation. Treatment for local regional recurrence. Breast conservative surgery. 20% to 30% with residual disease. Local recurrence, 14% to 48%. Re-irradiation. External beam RT. Brachytherapy. Selected patients, high complication rate. Treatment algorithm for MBC. Trastuzumab plus taxanes. HER2 plus SERM. SERD. AI. OFS. HER2. Trastuzumab plus capecitabine. HR- HR plus MBC plus anastrozole. Lapatinib plus letrozole. Lapatinib plus paclitaxel plus beva. Single agent chemo. Polychemo RX. Paclitaxel plus beva. Chemo RX plus PARPI. Metastatic bone disease. Bisphosphonates. Denosumab. BRCA. Mutated. DNA damaging CT. Olaparib. TDM1, Pertuzumab, Neratinib, Mtori. Hormone receptor positive breast cancer is treated with hormone therapy with or without additional chemotherapy depending on other patient and disease characteristics. Treatment may include tamoxifen, fulvestrant, an aromatase inhibitor, such as anastrozole, letrozole, exemestane, or ovarian suppression. Patients with HER2-positive disease should receive Herceptin regardless of their or other characteristics. Several trials have shown that Herceptin may be administered in combination with chemotherapy such as taxotere, 1, paclitaxel, 2, Zelida, 3, or Zelida/taxotere. Patients with hormone receptor-negative and HER2-negative disease should be offered chemotherapy. The most commonly used cytotoxic agents are the anthracyclines, the taxanes, Zelida, vinylbine, liposomaldeoxyribosin and gemcitabine. These agents are all used alone and in double or triple combinations depending on the patient and disease characteristics. For this particular patient, anthracyclines and taxanes would not be the best options as both had already been used in the adjuvant setting. Several novel agents are in development or in clinical trials for MBC. These include targeted agents such as Avastin and lapatinib and novel cytotoxic agents such as Abraxane, albumin-bound paclitaxel, and the apothalones. Other factors to be considered when choosing therapy for breast cancer include prior adjuvant therapy, the disease-free interval and the burden and distribution of the disease. 1. Extra Jm et al. Jacqueline Oncol 2005 /23:17s, Abstract 555. 2. Sleman DJ et al. Enengel Jmed 2001 /344-783-92. 3. Schuel et al. Breast Cancer Street 2005 /94 supple. 1, S94, Abstract 2031. 4. Wardley et al. Breast Cancer Street 2005 /94 supple. 1, S281, Abstract 6094. Metastatic bone disease, bisphosphonates in breast cancer. 64% risk of skeletal complication with no bisphosphonate at 2 years. Approx 33% risk reduction with pamidronate. Further 20% risk reduction with zoledronic acid. Additional 18% risk reduction with denosumab. So where have we come from and where are we now? In the pre-bisphosphonate era, 64% of patients would have an SRE over 2 years. With pamidronate, the proportion of patients who had an SRE was decreased to 43%. With zoledronic acid, the proportion of patients who had an SRE was decreased to 34%, and with denosumab, approximately 27% of the patients with metastatic breast cancer will have an SRE. Therefore, with the availability of new therapies, the incidence of SREs has decreased nearly 60% during the last 15 years. 64%, 43%, 34%, 27%. Lipton A. et al. Cancer. 2000 /88 to 3033 to 3037. Rosen L.S. et al. Cancer. 2003 /136 to 43. Stopek A. et al. Echo/ESMO 2009. Abstract 2 LBA. What's new? Fulvestrant. AI. 35. 35. 35. Faslodex Arimidex. Duration of objective response, days. 200. 400. 600. 800. 1000. Fulvestrant 250 mg, N equals 52. Anastrozole 1 mg, N equals 45. 0.0. 0.2. 0.4. 0.6. 0.8. 1.0. Without visceral metastases. Proportion with objective response. Fulvestrant 250 mg, N equals 30. Anastrozole 1 mg, N equals 25. With visceral metastases. Faslodex. Faslodex. Bolero 2, ER plus adverb breast cancer, exemestane plus everolimus after recurrence or progression on anastrozole or letrozole. Postmenopausal women with ER plus locally advanced or metastatic breast cancer with prior recurrence or progression on letrozole or anastrozole. Stratification by sensitivity to prior hormonal therapy and visceral metastases. PFS. Survival. ORR. CPS. Col. Safety. PARC. Biomarkers. Everolimus 10 mg BO daily. Exemestane 25 mg BO daily. SCREEN. Randomize. 2:1. N equals 705. Placebo 10 mg BO daily. Exemestane 25 mg BO daily. Less than 21 days prior to day 1. 705 patients. Bolero 2, ER plus adverb breast cancer, exemestane plus everolimus after recurrence or progression on anastrozole or letrozole. Median progression-free survival was 6.9 months with everolimus plus exemestane versus 2.8 months with placebo plus exemestane. Hazard ratio for progression or death, 0.43, 95% confidence interval, C, 0.35 to 0.54, P less than 0.001. PFS, survival, ORR, CPS, col, safety, PARC, biomarkers, everolimus 10 mg BO daily, exemestane 25 mg BO daily, SCREEN, randomize, 2:1, N equals 705, placebo 10 mg BO daily, exemestane 25 mg BO daily, less than 21 days prior to day 1, 705 patients. Does lapatinib work in trastuzumab-resistant HER2-positive cells? Time to progression, ITT population independent assessment. Percent of patients free from progression. Capecitabine. Lapatinib plus capecitabine. Less than 0.001. P-value. 72. 49. Progressed or died. 4.4. 8.4. Median TTP, Mo. 161. 163. No. Of Peats. 0.49, 0.34, 0.71. Hazard ratio, 95% C. 100. 80. 60. 40. GSK approved slide. 20. 10. 20. 30. 40. 50. 60. 70. Time, weeks. Study EGF 100,151. Gayasi, et al. Edgem 2006 355, 2733 to 2743. MBC, RCTs after AT failure in unselected patients. Trial. Study population. Peats. Hash. ORR percent. PFS/TTP. Months. OS. Ixabep alone plus capecitabine versus capecitabine 1. AT resistant. 752. 35 versus 14. P less than 0.0001. 5.8 versus 4.2. P 0.0003. 12.9 versus 11.1. Versus capecitabine 2. AT pretreated. 1121. 43 versus 29. P less than 0.0001. 6.2 versus 4.2. P 0.0005. 16.4 versus 15.6. Gemcitabine plus vinylbine versus vinylbine 3. AT pretreated. 252. 36 versus 26. P 0.09. 6 versus 4. P 0.0028. 15.9 versus 16.4. Bevacizumab plus capecitabine versus capecitabine 4. 462. 20 versus 9. P 0.001. 4.9 versus 4.2. 15.1 versus 14.5. 1 Thomas et al., Jacqueline Oncol 2007, 25 to 5210 to 17. 2 Sperano et al., Jacqueline Oncol 2010, 28 to 3256 to 63. 3 Martin et al., Lancet Oncology 2007, 8, 219 to 25. 4 Miller et al., Jacqueline Oncol 2005, 23 to 792 to 9. Embrace Phase 3 trial of eribulin in heavily pretreated MBC. Patients, N equals 762. Locally recurrent or MBC. 2 to 5 prior chemotherapies. Greater than or equal to 2 for advanced disease. Prior anthracycline and taxane. Progression less than or equal to 6 months of last chemotherapy. Neuropathy less than or equal to grade 2. ECOG less than or equal to 2. 2 to 1. Eribulin malate. 1.4 mg/m2, 2 to 5 minutes 4. Day 1, 8q 21 days. Treatment of physicians. Choice, TPC. Any monotherapy, chemotherapy, hormonal, biological, or supportive care only. Global, randomized, open label. Primary endpoint, OS. Final analysis after 422 deaths. Median age 55.2 years, 16% HER2+, 19% TNBC, median 4 prior agents. 12C, et al. Jacqueline Oncol 28:7S, 2010, supple, obst TRA 1004 carat. Novel taxoids, improved tubulin targeting profile. Minimally recognized by PGP, M1. Bisseri MC, et al. Procamisoccat series 2000 41 to 214. Chemotherapy plus bevacizumab. Pooled efficacy analysis of bevacizumab plus chemotherapy versus chemotherapy alone. Outcome. Chemotherapy plus bevacizumab. N equals 1439. Chemotherapy alone. N equals 1008. Median PFS, MOS. 9.2. 6.7. HR, 95% C. 0.64, 0.57 to 0.71. ORR, percent. 49. 32. Median OS, MOS. 26.7. 26.4. 0.97, 0.86 to 1.08. 1 year OS, percent. 82. 77. Assessed in patients with measurable disease at baseline, N equals 1105 for chemotherapy. Plus bevacizumab, N equals 788 for chemotherapy alone. O'Shaughnessy et al. ASCO 2010. Abstract 1005. Types of drugs for inhibiting VEGF pathway. Drugs that target circulating VEGF. Bevacizumab. Soluble VEGF for decoy receptors that target circulating VEGF. Aflibercept. TKIs that target multiple tyrosine kinases, VEGF receptors, and other receptors. Sunitinib, sorafenib. Antibodies that target VEGF2 and VEGF1. Ramucirumab,